Hi, ladies and gentlemen. I'm M.Malbrain from Brussels, Belgium, and will give a lecture on everything you need to know about fluid therapy. It's a story on the 7Ds, 4 phases, 4 questions, and much more. This is part 1. These are my conflicts of interest. My biggest bias being the co-founder of the International Fluid Academy. I'm very fortunate to have met Mathilde, Her Majesty, Queen of the Belgians, as well as Philip, His Majesty, King of the Belgians, during the first wave of the COVID pandemic. Also, Maggie, former Belgian Minister of Healthcare. This lecture will be about breaking bad habits. The following slides are courtesy of my good friend Ross Fisher. I want to take you into the matrix. The matrix is real, and our current understanding of fluids is part of the matrix. It is a virtual reality. Morpheus offers Neo a choice in the matrix to reconsider his life. And I will show you one single phrase to get out of this virtual reality. This phrase is, fluids are innocent bags of water. This is the basis of our current understanding. This is the matrix. I would like to challenge a new idea. Fluids are not innocent. Fluids are not just a bag of water. Fluids should be treated as drugs. Morpheus offers Neo a choice. He could either take the blue pill and continue to believe that this world is as you see it, so fluids are an innocent bag of water, or you can take the red pill and reload. During my lecture, I will explain the 7Ds of fluid therapy. D1 on definitions. D2 on diagnosis of volemic status, hypovolemia, hypervolemia. D3 is all about fluids as drugs. D4, dose. D5, duration of treatment. D6, de-escalation fluids. And D7, what after discharge of the patient. So when we multiply D1 to D7, this equals D to the 7th power. And this equals fluid stewardship. So the first D is not just on the what or the so what, but on the definitions surrounding fluid therapy. I don't want to overload you with boring definitions, but I will point out the most important ones. Fluid balance, you're all very familiar. It's the daily sum of the fluid intakes and outputs. Fluid overload is calculated by dividing the cumulative fluid balance in liters by the patient's baseline body weight multiplied by 100. A fluid overload is defined by a cutoff value of 10% of fluid accumulation, and this is associated with worse outcomes. Early goal-directed fluid management is as it is advocated by the Surviving Sepsis Campaign guidelines and is around 30 ml per kilo within the first 1 to 3 hours. Late conservative fluid management is defined by 2 consecutive days of negative fluid balance within the first week of ICU stay, and late goal-directed fluid removal is active fluid removal by means of diuretics or renal replacement therapy with net ultrafiltration. And this is what we refer to as de-escalation or de-resuscitation. So while fluid overload is usually accompanied by hypervolemia, hyperhydration, and peripheral edema, and hypervolemia is almost always associated with edema, peripheral edema does not necessarily mean that the patient is hypervolemic. So that is why Jean-Louis Vincent suggested that maybe we should avoid the term fluid overload. So there are many definitions surrounding fluid therapy. I will not go into detail now, but I will explain them during the rest of my talk, like hypervolemia or hypovolemia, overhydration, fluid underload, and so forth. What is a fluid challenge? Fluid bolus? What is preload, afterload? Body composition, the ebb and flow phase, global increased permeability syndrome, and then dynamic phases of fluid therapy. This brings me to the second T. It's not just the what, it's the diagnosis of the volemic status of the patient. We know that hypovolemia is bad. The application of what we already know will have a bigger impact than any technology likely to be introduced in the next decade. Any drug or fluid or technology likely to be introduced. So we need to make better drugs, and we need to make good drugs better. So we also need to make good fluids better by using them wisely. And we all know that when it comes to using antimicrobials, they're often given longer than necessary without infection and just for colonization. So it's around 30% that is inappropriate. So maybe if we would write a paper today with the executive of the Fluid Academy, we would probably found that fluids are given inappropriately in about 50% of cases. While hypovolemia is bad, hypervolemia is even worse. Hypovolemia leads to convective problems when oxygen cannot get to the tissue. Hypervolemia will result in diffusion problems and interstitial edema, increased abdominal pressure, and end organ dysfunction with increased morbidity and mortality. So we need to find euvolemia or normovolemia. Fluid status matters. And there are a lot of myths surrounding fluid status and fluid therapy in general. Septic patients are not always hypovolemic. Surgical patients are not always hypovolemic. Sepsis does not mean that the patient has increased amounts of insensible loss. Peripheral edema does not mean that we need to give the patient diuretics. And a low preload does not mean that we need to give fluids to our patient. Brings me to the definition of preload. And preload is defined as the stretch on the actin myosin fibers of the heart before contraction. And in real life, we have a combination of preload and afterload. So the preload is the left ventricular end diastolic volume, while the afterload is the left ventricular end systolic wall stress. So this is a theoretical concept. For me, ideally, preload is a combination of parameters that tell me if fluids are needed and can be given safely. So whenever there is a therapeutic dilemma, meaning that each therapeutic option may carry some harm for the patient, we need to think beyond just cardiac output. So it's all about the benefits of fluids and the risks of fluids. Preload can be defined by barometric parameters like the traditional central venous pressure or pulmonary capillary wedge pressure, or volumetric preload indices like global endostolic volume, right ventricular endostolic volume, or ultrasound, the left ventricular endostolic area. We need to assess fluid responsiveness with functional hemodynamics like SVV, PPV, and fluid responsiveness tests like the passive leg raising test or the end extremity occlusion test. And the risks of fluid overload are examined by the impact of fluid accumulation on end organ function like lung water, pulmonary vascular permeability index, PF ratio. And we know that other parameters like intra-abdominal pressure, intrathoracic pressure, mechanical ventilation with high PEEP has an impact on all these preload parameters. Fluid status matters. And there are some clinical signs of fluid status or hypovolemia. And these signs are usually aspecific. Capillary refill time may be interesting, and presence or absence of peripheral edema, for instance. Other signs to assess fluid status are divided into laboratory signs, like signs for hemoconcentration, like an increased total protein and albumin ratio, or signs of infection and inflammation. Urinary electrolytes are very important. Other signs are related to monitoring, like presence of fluid responsiveness, low blood pressure, positive passive leg raising tests, and so forth. Imaging tests, well, a dry chest X-ray is usually black X-ray without curly B lines. On ultrasound, interesting to look at vena cava collapsibility index. And organ function signs relate to hypoperfusion of the end organs, and this can lead to DO2-VO2 mismatch and increased lactate production. Fluid status matters. So what about osmolality and tonicity? Osmosis is the movement of water across a semi-permeable membrane. It's the number of osmoles per solute kilogram solvent. So we can calculate serum osmolality with this formula, with glucose and sodium being the most important drivers. So tonicity is the effective osmolality. Tonicity is not the same as osmolality. Slide from Niels. Tonicity reflects the distribution of a fluid, while osmolality expresses the tolerability. And you can have a look at osmoles versus effective osmoles, as some will cross semi-permeable membranes and will have an active effect on tonicity. That's why different fluids may have different osmolality and tonicity. Tonicity describing distribution of the fluid in the body. And we know that the human body mainly consists of water. Around 2/3 is the total body water. Of this, about 2/3 is intracellular water and 1/3 is extracellular. And of the extracellular water, 3/4 is interstitial fluid, while 25% constitutes the intravascular or circulating blood volume and fluid. So if we would give isotonic 1 liter saline 0.9%, we would find out that after 1 hour, about 250 mLs of this liter will be intravascularly and 750 interstitially. If we would infuse 1 liter of hypotonic glucose 5 or dextrose 5 solution, we will find that most of this fluid will go intracellularly, about 2/3, while after 1 hour, only at max 10%, 83 mLs, will remain intravascularly. If we would give hypertonic saline, 3%, we assume that administering this fluid will attract fluids into the interstitial intravascular space at an excess amount. So maybe after 1 hour, we will have more than 250 mLs intravascularly. While administering colloids, we assume that the total volume of colloid infused will remain intravascularly after 1 hour. So therefore, remember that hypertonic solutions will remain 10% intravascularly, crystalloid solutions either balanced or saline about 25 to 30%, while colloids will remain, at least in the first hours, 100% intravascularly. Body composition difference with respect to age, anthropomorphy, gender, and so forth. And in this animation, you can see that when you have an insulator like fat, the electric current with the bioelectrical impedance measurement will not pass completely. Whereas if you have muscles of water, this current will pass very easily. So bioelectrical impedance analysis reports the ratio of insulation tissue like fat over conductive tissue like muscles or water, and this gives us the impedance. Impedance can be measured with multi-frequency and multiple electrodes, total body impedance. Usually fluid overload and edema will result in low impedance. So, D3, fluids are not an innocent bag of water, but should be treated as drugs. Of course, first, we must not do harm in medicine when treating patients, but we must ask ourselves different questions. Surrounding fluid therapy, there are 4 important questions. First one, when to start IV fluids, because the best fluid is the one that has not been given unnecessarily. Second question, when to stop fluids, when they are no longer needed, or when the patient has an oral fluid intake. Some patients will end up with fluid accumulation and will not transgress spontaneously from the ebb to the flow phase, as you can see after tubular necrosis, the polyuric phase, and may need active fluid removal. And when we are removing fluids, of course, we must avoid hypoperfusion, and at some point we stop fluid removal. These are the 4 questions. There are only 4 indications for fluid therapy. The first one being for resuscitation. Resuscitation fluids should save lives. These fluids received most of attention in the literature. And the publication of the big fluid trials like the VICEP, the Christmas, the 6S, the CHEST, the SPLIT, the Crystal, the Albios, SMART, SALT, Relief, resulted in a lot of reactions in the scientific community. But the bottom line is that when it comes to fluids in surgery and trauma, starches are not a good choice. They can be given. Gelatins, not much data. Saline in large amounts is not a good choice, and hypotonic solutions neither. So I think balanced crystalloid is a good first choice, and of course blood should be given, taken into account the shelf life and fluid strategy being important. When it comes to fluids in sepsis and the ICU, no starches, gelatin, saline, or hypotonic solutions. And again, balanced crystalloids are a good first choice. Blood when needed, and albumin 20% may be indicated in some patients with severe sepsis and shock, not transgressing from the ebb to flow phase, so for de-resuscitation. Fluid strategy, more important than the fluid per se. So, while resuscitation fluids received the largest attention in the literature, the largest part of fluids given is from another type. In this study by Niels van Regenmartel on almost 15,000 patients and 100,000 patient days, they found that only 6% of total fluid volume administered was for resuscitation, 25%, maintenance, 33%, nutrition, and 33% was fluid creep, meaning fluids that seeped into the patient for administration of drugs like antibiotics, painkillers, and so forth. 33% is fluid creep. Third indication is maintenance fluids, and they should cover the daily needs of water, glucose, sodium, potassium. For water, it's about 1 ml per kilo per hour, glucose 1 to 1.5 gram per kilo per day, and sodium, potassium around 1 millimole per kilo per day. These solutions, maintenance solutions, received little attention. And in this study in healthy volunteers by Niels van Regenmartel and co-workers, it was found after 2 days of fasting and only receiving maintenance solutions and comparing isotonic, so saline-based, versus hypotonic, glucion 5% ready from the shelf, that urine output was much higher in the hypotonic solutions, and fluid balance over these 2 days was about 1 liter less positive. This study was then carried out in critically ill patients undergoing major thoracic surgery, the TOPMAS trial. Patients were followed for 3 days, and again, after 3 days, fluid balance was on average of 1.5 liters less positive when hypotonic maintenance solutions were given. And this is probably the reason when you come to Belgium and have a Belgian beer in a bar, you always get salty peanuts. Beer being hypotonic, together with the salt, makes it isotonic. So you're more thirsty, you drink more, and you have less diuresis. So it's a win-win for the bartender. Replacement fluids should mimic the fluid that is lost, and gastrointestinal losses may be the only indication for abnormal saline, because you and I don't have 154 millimoles per liter of chloride nor sodium in our serum. Often forgotten, nutrition fluids should cover the caloric needs, but for administering calories, we need also to administer fluids either antrally or parenterally. This brings me to the rest of the 4 Ds, so D3 being drug. And intravenous fluids should be treated as drugs, and in analogy to antibiotics and antibiotic stewardship, the type of fluid is important. Therapy should be appropriate, maybe combination, and the timing should be appropriate. So slides from Niels shown that there will be more organ failure and longer ICU length of stay with inadequate antibiotical treatment. And patient risk factors determine our empiric antibiotic selection. So if we now compare antibiotics on the left and fluids on the right, when it comes to inappropriate therapy for antibiotics, we know that this leads to morbidity, and probably the same holds true for fluids, because we will have more hyperchloremic metabolic acidosis, AKI, renal replacement therapy, and increased mortality if fluids are given inappropriately. When it comes to the appropriateness of therapy for antibiotics, we take into account for empiric treatment prior antibiotics, duration of ventilation, whether the patient received corticosteroids, nursing home, recent hospitalization. So for fluids, which should also take into account pre-existing fluid balance, capillary leak, source control, kidney function, organ function. So when it comes to combination therapy of antibiotics, we hope to have a broader spectrum, synergy, less resistance, but there may be drawback of more toxicity. With fluids, we have specific fluids for different indications. So for antibiotics, it's a pragmatic approach in the empirical setting, a short course of combination therapy, but definite treatment, probably not. So in fluids, we do it all the time. So for resuscitation, trauma, we may have blood and crystalloids. In sepsis, maybe crystalloids early, albumin late. With operative, you could use starches and then crystalloids. For maintenance, we can have ready from the shelf solutions, some nutrition, maybe some normal saline as fluid creep, for drug delivery, and so forth. So when it comes to the appropriate timing, we know from studies that survival decreases with about 7% per hour delay. And probably if a patient is in septic shock with hypovolemia, fluid delay will result in microcirculation hypoperfusion. So for antibiotics, we know this very nice study by Kumar, where you see that every hour delay is related to an increase in mortality. Appropriate timing for fluids is also important, has been shown in this study by Murphy, albeit retrospective, in patients with sepsis, where inadequate fluid initially and late conservative fluid management, remember it's 2 consecutive days of a negative fluid balance within the first week of ICU stay. Here, highlight in red, carries a better prognosis than you give too much fluids and keep on giving liberal fluids afterwards. Brings me to the next T. So fluids are drugs. Default, the dose is important. As Paracelsus already stated, alle Dinge sind Gift und nichts ungift, allein die Dosis macht, dass ein Ding kein Gift ist. Translated in English, all things are poison and nothing is without poison. Only the dose permits something not to be poisonous or to be toxic. It's the dose that makes the poison. So this is a key concept that we are very familiar with when it comes to antibiotic therapy, where we have the pharmacokinetics, which describes how the drug, the antibiotic, will interact with the host. So it's the volume of distribution. And the pharmacodynamics determine how the antibiotic will act on the bug. Pharmacokinetics refer to therapeutic drug monitoring, and we need to correct the dose in AKI, and pharmacodynamics is the kill characteristics. Here we have two major differences, time versus concentration dependent antibiotics. So if we look at pharmacokinetic principles for antibiotics, as stated, distribution volume is important, clearance, albumin level, tissue penetration, but the same holds true for fluids. Type of fluid, distribution volume. I told you about osmolality, which is the tolerability of the fluid, and the tonicity will refer to distribution of the fluid, and kidney function is important. So what happens to blood volume if a fluid is infused? Well, as long as a fluid is infused, the blood volume expansion is 50 to 100%. And the reason for this is slow distribution. So what about distribution? Well, if blood pressure decreases by 20%, crystalloid distribution stops. So during surgery, after induction, anesthesia, patients in shock, you will see that 100% of the infused fluid then remains in the blood, whether it being crystalloid or a colloid. And the reason for this is Starling mechanism. These are very nice studies done by Robert Hahn. So excretion of a crystalloid fluid is very slow during anesthesia and surgery. And blood volume expansion is maintained. Reasons for this is many unknown, and this compared to a conscious volunteer where the fluids are very rapidly excreted. These are pharmacokinetics. So what about the pharmacodynamics? For antibiotics, we look at mean inhibitory concentration, kill characteristics, time above the MIC, and then the peak-MIC ratios. And we know for some antibiotics, like aminoglycosides, they are concentration dependent, and beta-lactams are time dependent. So for fluids, it's not different. So the type of fluid is important and where you want the fluids to go. If it's intravenous, you need resuscitation. If there is cellular dehydration, you need to give hypotonic solutions. So key concepts for the dose of fluids for maintenance, as already alluded to, it's 1 ml per kilo per hour. Resuscitation, you have the goal-directed treatment. There's a lot of discussion on that. But classically, fluid bolus should be around 4 ml per kilo given over 10 to 15 minutes. So it's like of a small volume resuscitation. We know that replacement fluids may cause fluid creep, as well as fluids used to dilute or drugs in. And remember that 6% is resuscitation, 25 maintenance, 33 nutrition, and 33 is fluid creep. So when we look at the response to IV fluids, we learn from literature that static surrogate parameters are often useless, like stating target a CVP 8 to 12, a MAP above 65, urine output above 0.5 ml per kilo per hour. Dynamic functional hemodynamic parameters like PPV, SVV are more interested, and tests to predict fluid responsiveness like a passive leg raise or end-expiratory occlusion test should be performed. So static parameters are not useful. So other key concepts if we translate fluids to antibiotics. Fluids will also have a therapeutic dose, effective dose, a toxic dose, and a lethal dose. And this is important, and cases have been described in water poisoning or patient dying after excessive hypotonic solutions. Again, comparing antibiotics and fluids, when it comes to toxicity, we know that some antibiotics are toxic and we need to adjust the dose, but not getting infection under control isn't helping the kidneys either. Not getting shock under control is not helping the kidneys either. For some fluids, there is a maximum dose, like starch is about 30 ml per kilo. This is the end of part 1 on everything you need to know about fluid therapy. Thank you for your attention.